Okay, hello, it's now 3 o'clock, and with that, I would say we start. Welcome to the Protective Ventilation webinar series from Dräger. Today at the June the 24th of, and with the year 2021. Hello to all of you. Before we start, the official disclaimer. The webinar presentation is for information purposes only and has no commercial background. Dräger has neither influenced the content of the presentation nor taken editorial measures. The sole responsibility for the content of the presentation and the webinar lies with the author. All views expressed or information given are those of the author and are in no way attributable to Dräger. Now, before some technical details, recording of the webinar. Please note that this webinar is recorded and the recording will be distributed afterwards at the end of the webcast. In order to know if you can hear me properly, I would like that you maybe shortly raise your hand so that I know that you can hear me. This seems to be the case. So this is fine. And yeah, many thanks for that. Regarding questions and answers, please write your questions in the question field. You can see that here on the right side. All the questions will be answered by the speaker at the end of the presentation. In case we run out of time, all questions will be addressed to the speaker and will be answered afterwards. And with that, a warm welcome to our webinar today with the title, How to Optimize Lung Protective Ventilation. My name is Harald Börner and I'm the responsible marketing manager for intensive care in Dräger in the region Europe. And together with my colleagues of the European marketing team, we are welcoming you to this webinar. This is a webinar series on protective ventilation organized by Dräger. You will automatically receive a copy of today's slides and a link to access the recording in the next couple of days. But please be aware, to receive the slides and the link, for data privacy reasons, you must have clicked the opt-in link when you first registered. So you got an email sent from Drägerwerk AG with the subject, just one more step, please confirm your email address. If you have done so, we are then allowed to send you the follow-up information. This only applies if you have not done that. If you have already done that, then this is fine. And with that, I'm very happy to introduce our host to you today, Professor Giuseppe Foti. He is Associate Professor of Anesthesia and Intensive Care at the University of Milano Bicocca. Professor Foti is also Director of Emergency Department of ASST Monza and Director of the Intensive Care Unit of San Gernando Hospital as well in Monza. He's a world-leading expert in the field of mechanical ventilation with several publications on lung protective ventilation, lung mechanics, and intensive care management. I'm very, very pleased and happy to have you today with us. And with no further words, I would now hand over to you. Hello, can you hear me?
Yeah.
That is
Let's
great.
see if I can do anything properly. Okay.
Very perfect. So
fine. You see me?
I can see you, I can see the presentation, and the sound is great. So I will mute my mic and I will switch off my camera and the stage is yours.
Okay. So thanks a lot. Thanks to Dräger and thanks to all of us that wanted to share those, let's say, 45 minutes together talking about on how to optimize lung protective ventilation. As As you already know, I'm working in Italy, Monza, and I would like to, first of all, share with you my conflict of interest, and more importantly, start with you to see the problem, okay? So this slide is a very old one. This is a CT scan of a patient many years ago, in which you can see clearly the problem, extreme problem of barotrauma, ventilation that was not properly set. Here we have bubbles, pneumothorax, and everything. But we don't have to think about as a barotrauma as only a problem so extreme. It's something that occurs also at the cellular level. This is a very, very, very important study of many years ago that clarify the vast majority of the problem related to the barovolotrauma affair. It's an experimental study. To make a long story short, if you use, those are indicators of lung damage, 1, 2, and 3. Those are the normal level. If you apply high pressure and high volume to a normal lung, you induce lung damage. If you apply high volume with the low airway pressure, as you can do with the iron lung or a negative pressure ventilator, you're getting lung damage. If you apply high pressure but with a low volume, as if you, for example, you do a chest binding in order to decrease chest wall compliance, you do not get lung damage. So this study demonstrated clearly that the problem was the volume. The pressure is just an indicator, but the main problem was the volume. And in order to have an idea how is the respiratory mechanics of our patient, which patient are we talking about? We're talking about mainly a patient with an ARDS, okay? And we construct pressure volume loop. This is the normal pressure volume loop of a normal subject under general anesthesia. This is a pressure volume loop instead of a patient with an ARDS. They are very different. As you can see, you can find lower inflection point, vast majority of cases, an upper inflection point. And those points do reflect, in this case, a major recruitment along this part of the pressure volume diagram. And the upper inflection point instead clearly identify over distension in our lung. I want you to focus on this part now, because I just told you that we have a problem when we use too high tidal volume. But there is also a problem when we do use too lower value of PEEP, in order that in so doing, we promote what is called atelect trauma, opening and closing of alveoli. If I'm lucky, maybe we could share this video. In this video, here we have video microscopy. Those are alveoli, and those are alveoli in a lung ventilated with a low PEEP, almost zero. And as you can see below, certainly the lower inflection point. You can see all those alveoli that are opening during tidal ventilation, this one. Instead, if we move to a PEEP level that is higher, the lower inflection point, you see those alveoli that we here are opening and closing, here they stays open. And this is certainly a way to avoid atherosclerotic trauma. That is another way to promote lung injury by mechanical ventilation. So a certain amount of PEEP and doing pressure volume. Sorry, let's see if we can move ahead. Okay. And it does occur atherosclerotic trauma in patient or only in experimental situation? No, it does occur also in patient. This is a CT scan study in which the yellow part is the amount of lung that opens and closes during ventilation. It is maximum at a very low PEEP value, and it decreases when you increases the PEEP value. See, going to 10, 15, then it decreases. Still there is some, but it decreases. So applying a certain level of PEEP do reduce the atherosclerotic trauma phenomenon. How can we then construct our pressure volume loop? The most convenient method that now is largely applied all over the world is the, sorry for the Italian, insufflazione lenta. It means slow inflation technique. If you apply a very low flow, what I mean for very low flow, below 9 liters per minute, you decrease the resistive drop, and the changes during time of the pressure do reflect accurately, precisely, the alveolar pressure. So very simple for a machine to do this kind of maneuver, very easy to do, quick, and at the end you get the pressure volume loop. In this case, you see there are no major inflection point. It's a straight line, differently from the other patient that we saw at the beginning of my presentation. So, pressure volume curve to identify lower inflection point that we have to avoid large phenomena of atherosclerotic trauma, and upper inflection point to avoid overdistension. This is just the beginning of the story. Now, I want you instead to present something that is maybe less known, but is very important, and I do believe on it very much. It is something that is, in a way, new. But I was so lucky to work in the Ted Kolobov lab many years ago. And Ted Kolobov, that passed away a few years ago, was a real genius. And already in 1988, he did understand something very relevant that we forgot for so many years. That also you can have lung damage, not by mechanical ventilation, but just because of excessive tidal volume on spontaneous breathing, no ventilator. Those were sheep that were forced to hyperventilate, injecting salicylate in the cisterna magna in order to promote hyperventilation. And in few hours or days, they develop ARDS. Exactly high tidal volume, no airway pressure, high airway pressure, certainly high transpulmonary pressure, and they develop ARDS. So this is very, very important. I will go back to this one. The first clinical message that we have to be very careful to tidal volume, also not only during controlled mechanical ventilation, but also during spontaneous breathing. In fact, usually you think about the term VILI, ventilator-induced lung injury. But now you have to think about a new term, let's say, a new concept, very straightforward, very straightforward. Self-induced lung injury. The possibility that our patient do destroy their lung because of too much effort while they are spontaneously breathing with the tube or without the tube. So I want to concentrate at this point on the issue of NIV in ARDS patient and the possibility that in this case, if we are not very careful, we can have silly lung damage because of excessive ventilation even before we get our patient in the ICU or when we do apply NIV. This study performed by my colleague and some other, the lung safe study, my colleague is Giacomo Bellani. It was an observational study all over the world about ARDS. This is a part of the study in which they investigated the role of non-invasive ventilation in patients with ARDS. Apparently, in this study, applying non-invasive ventilation, it doesn't change the outcome instead of not doing it. But if you consider patient with a PF ratio below 150, so the most severe one, it appears that non-invasive ventilation may impair outcome, may increase mortality. So this is something that we have to keep in mind. Remember, I do use non-invasive ventilation in ARDS, and I did use a lot, especially during pandemic. But we have to think about. First consideration. All over the world, non-invasive ventilation means in more than 90% of the patient, mask PSV. PIP plus pressure support with a face total or orofacial mask. And I want you consider the risk of keeping spontaneous breathing, high tidal volume, high inspiratory pressure. There are experimental data that suggest that if you get a mild lung injury subject and you apply spontaneous breathing, the situation gets better. But if you get a severe lung injury and you apply spontaneous breathing, you're getting a worse injury. This is an old study, and I want you to concentrate on a very simple physiological data. Those are patients with acute lung injury, moderate ARDS, as we called it a few years ago. Look at the tidal volume. During spontaneous breathing, applying CPAP, tidal volume goes down, respiratory rate goes like a minute ventilation goes down. We have a recruitment, and possibly the patient it breathes less. Then if we apply pressure support, then the tidal volume goes up and the minute ventilation goes up. Remember, those patients, they do ventilate already a lot. We don't have to confuse what is the target on a COPD patient to improve ventilation and the target on an ARDS patient, that is, to improve recruitment and oxygenation. If you apply pressure support to an ARDS patient, you obtain, on average, an increase in minute ventilation. Is it a good idea? This is a more recent study, striking one, if you did follow me till this point. Those are patients with, once again, ARDS, de novo acute hypoxemic respiratory failure. And these are the tidal volume of those patients during PEEP plus pressure support. Half of the patient do breathe on his own, plus the pressure support, with a tidal volume above 10 and even 12 ml per kilograms. 12 ml per kilograms on pressure support NIV. And the most severe one, which one of the most severe one do fail in NIV? The one that have the highest tidal volume. So this is an indirect evidence that do exist CD. Would you apply a tidal volume of 12 ml per kilograms in a patient intubated with ARDS? The answer is no. It is reasonable, it is wise to keep it instead 1 hour on pressure support on non-invasive ventilation. I do like CPAP as a method to treat patients with ARDS before intubation, to avoid intubation. And the evidence that CPAP is dangerous are lacking, or could be potentially dangerous. This is a study with the helmet. You know, in Italy, we are also fanatic about helmet CPAP, in which helmet is better than face mask in patients with acute respiratory distress syndrome. There is a meta-analysis on Italian data done by Chinese authors in which they demonstrated that in patients with, once again, hypoxemic acute respiratory failure, helmet CPAP, it is better than conventional treatment with the oxygen. So data demonstrating that CPAP can be dangerous are lacking. So as a summary of this, on my part, talking about lung protective ventilation, I wanted to concentrate also on the part of before intubation. Usually we think that the lung protection should occur only after intubation. I'm telling you, no. I do think differently. And I'm telling you to be aware of self-induced lung injury. The PSV may be dangerous in such subject. There are no evidence that CPAP is dangerous in this patient. And if you have an evidence that the patient is going in a silly direction, please do not hesitate to intubation and control ventilation in such patient. Those are, I'm finishing with NIV. And just one data regarding the COVID pandemic. We had a lot of patients on helmet CPAP in Lombardy. As you know, Lombardy, especially during the first wave, was overwhelmed by patients. And what we found that in patients undergoing helmet CPAP, there is a very, very different outcome if they have an PF ratio during helmet CPAP above or below 150. They are above 150 and still improving They do well in the vast majority of cases. Instead, if the PF ratio is below 150, the scenario is much worse. And in this patient, you should concentrate. I do concentrate in order to intubate as soon as I can if intubation is indicated for other reasons. Then we have finally our patient intubated. We know very well that our first goal is to keep a tidal volume around 6, maybe 8 ml per kilogram of ideal body weight. First of all, a very simple concept. There are many ways to identify the ideal body weight. We use this one that is very simple, maybe not precise, but it can be done in ICU patient. In man and woman, they are different, the ideal body weight according to the height of the subject. I know you know very well this formula. Now I want you to concentrate on something. Let's assume I have a normal Italian woman, 160 centimeters tall, so an ideal body weight of 50 kilograms, 50. So my target tidal volume would be around 300 ml. Can I afford, as a humidifying system, an HME filter in a patient with a 300 ml tidal volume target? The answer is no. So we should try to promote active humidification instead of passive humidification in order to facilitate lung protective ventilatory strategy. Then, so far I talk about ml per kilograms, but I think thanks to Marcelo Amato, in the last few years, we changed significantly our approach and we switched more and more toward driving pressure, very, very simple parameters. Plateau pressure minus PEEP. Auto PEEP is not an issue in such a patient in the vast majority of cases. In this case, you see a patient ventilated with a plateau of 30, a PEEP of 5. The driving pressure is 25. And this driving pressure is 25 is a bad number. We know it. We know it from the study of Marcelo that demonstrated clearly that higher the driving pressure, higher the mortality. And usually we consider 14 of driving pressure, 15 as a safe number, just because this number is the average mortality of the study of Marcelo Amato. So the point is, why driving pressure it is better than tidal volume milliliter per kilograms? Because it is, driving pressure is tailoring, is personalizing the tidal volume to the, not to the size of the subject, but to the size of the open lung. So it's a bit more intelligent than ml per kilograms. And I do use this example that I want to share with you. Let's assume we have, once again, 2 ARDS in an Italian woman, in 2 Italian women, 160 centimeters tall. So the ideal body weight is 50 and the ideal tidal volume is 300 ml. But one lady has these ARDS, bad lung, but still a lot of aerated part of the lung. There is gases inside. We measure the compliance of the subject. We have 40. 40 of compliance in a 50 kilograms subject is approximately 80% of the expected. In fact, the vast majority of the lung is open. So the tidal volume is 300 ml, the compliance is 40. How much is the driving pressure? 7.5. It's a very safe driving pressure. But let's assume we have another lady with an RDS, 50 kilograms, same target of tidal volume of 300 ml, but with this CT scan, a compliance of 15. Why 15? Look at this line. Half is totally closed, and the other half is very bad. The compliance 15 is approximately 30% of the expected. But if we have 300 ml on a lung with a compliance of 15, it's very easy to calculate that the driving pressure is 20. So in this case, 300 ml is okay. It's a good tidal volume. In this case, 300 ml is not okay. We should use a lower value unless we are capable of improving the compliance of the subject. So in this way, I want to share with you the idea that driving pressure is a bit more smart than ml per kilograms. Now, one of the ways to improve and to reduce the driving pressure is to improve compliance. And which way do we have to improve compliance? Certainly to promote alveolar recruitment. You see here a lung and a CT scan of a lung that is very, very much recruitable, going up with the pressure. You see that almost you open up completely the lung. Now, let's go and see what is the rationale of the recruitment and of the recruitment maneuver. This is a lung of a patient with ARDS at 0 PEEP. Then we apply a PEEP above the lower inflection point. And you see that there are certainly some recruitment, but there are a lot of parts of the lung that are closed. Then we go to vital capacity. Let's say 40 centimeters of water of pressure. And you see full recruitment of those lungs. And then, be careful now, we go back to the pressure of the point B, but following the recruitment maneuver. So the pressure in the slide B is the same of the pressure in the slide D, but the lung is much more open. This is the concept of recruitment. Open up the lung, then stays open when you decrease the pressure. That's very important. And it occurs in many patients, especially at the beginning of the disease. How can we apply? How can we perform a recruitment maneuver? There are many ways. I share with you the mode that I use since many years. I do use the sustained inflation technique, only so one maneuver for a long period of time. When I mean long, I mean 20 seconds. And how can I do it? With the Dräger ventilator, the most convenient way, in my opinion, I am on volume control ventilation. I switch for one breath to APRV set in this case to a pressure of 40 centimeters of water. I keep it for 20 seconds, one single breath, and then I move back to volume control ventilation. Very easy, safe, and obviously you have to be very careful, but with a little hemodynamic impairment. I'm not gonna discuss other maneuvers that I think are more dangerous. This is the way I use in my clinical practice. This is another way to see the maneuver. The pressure that we apply, it depends on the subject, but is around between 30 and 45 centimeters of water. The period, as I told you, is 20 seconds. We usually apply only one maneuver and see the effect, and then we're gonna go back to this point later on. The mode that I use is a PRV. During the maneuver, I check the blood pressure, and following that, I look at saturation, PO2, and other factors. But let's start with the saturation that I know is very popular. Well, I don't know if it's popular, then you let me know. The most simple way, let's say a Friday night ventilation, 2 o'clock in the morning, maybe is this one. Those are patients that do respond in terms of oxygenation to a recruitment maneuver. They all do respond. You can see here saturation going up. But following the recruitment maneuver, going back to the previous PEEP level, previous means before the recruitment maneuver, the saturation then go back. And let us concentrate on the cases. Let's assume we concentrate on this patient, the red, Mr. Red, okay? With a PEEP of 7, I do a recruitment maneuver, saturation do improve a lot. I go back to 7. This is what I do on my clinical practice. And following that, the saturation goes back to the previous value. It means this lung is recruitable, but with 7 of PEEP cannot stay open. So I do repeat the maneuver, but I do apply higher level of PEEP. In this case, 10 was capable to stabilize the alveoli to have a sustained improvement in oxygenation. Let's consider instead Mr. Green. With the 10 does not stabilize. Okay. With 12 does not stabilize. With 15, finally, we achieved the stabilization of the oxygenation. Okay. I talk about saturation and PO2. Okay, this is the most convenient, easiest, but I do not think is the best way to evaluate recruitability. PO2 is influenced by many factors, not only recruitment, but metabolic, circulation. So maybe it is much better to evaluate compliance, changes in compliance following a recruitment maneuver. Also keep in mind PCO2. If following a recruitment maneuver, at the end of the story in our ventilator setup, PCO2 should be the same or maybe slightly lower than the basal one. If it goes up, something is wrong. Something has to do with over distension, increasing that space that we should keep in mind. Then there are other systems, bedside lung ultrasound or electrical impedance tomography, that make much more precise the selection of the PEEP value and to understand if the patient is or it is not recruitable. I want to concentrate on EIT. The technique, I go quickly, does allow us to evaluate changes in impedance, so distribution of ventilation and the inflation of the lung. And this is the way that we use it in our clinical practice. That is very similar to the approach that I show you with the SpO2. But instead of using the SpO2, we use the end expiratory lung volume measured by EIT. So we have a patient here. This is the end expiratory lung volume. This is the tidal volume. We apply, see the recruitment maneuver, look at here. Then the patient goes back to the previous, to this PEEP level. But as you can see, following the recruitment maneuver, the volume is higher. This is recruitment. Same level of PEEP, higher volume inside to the lung. But during time, you see, we lost it. It means that this lung is recruitable, but the PEEP is not enough to keep it open. So we do repeat the maneuver and we apply 2 centimeters more of PEEP, and then we stabilize mechanically the lung. If we compare using oxygenation or using compliance to evaluate recruitment, having as a gold standard the EIT, what do we end up with? That there is no much correlation between oxygenation and recruitment. Instead, there is a much better correlation of recruitment with changes in compliance. But we are very, very careful on measuring compliance, because small changes of compliance, they do mean a lot. If you have an impedance tomography, as you saw before, it is very easy to understand if a lung is recruitable, very easy. And also very easy to understand if it can stabilize. Finally, this is more complicated, I do understand, but it's very fascinating, and we do use it in clinical practice. Meaning, following a recruitment maneuver, this is a PEEP trial with a different level of PEEP. The software is capable to distinguish between over-distension of the lung and de-recruitment. So you can select the PEEP level that promote the lowest value of over-distension, with a good compromise in terms of de-recruitment. In this case, a PEEP level around this one. How often I do recruit the lung? Not much often. Why? Because we use Sigh. And actually, Dräger, it was the first, now it is not the only, but is the first ventilator that do provide feasible way to promote Sigh during controlled mechanical ventilation and partial ventilatory support. The way it gives Sigh is you can select the amount of PEEP that you can change once every 3 minutes for 2 consecutive breaths in order to increase the lung volume and to promote a sustained inflation. The last model of Dräger ventilator are more flexible. You can change the number of breaths that you can have at the high PEEP level. You can change very conveniently also the frequency, every 3, every 5, every 10 minutes. What is the effect of Sigh on patient with ARDS? We studied many years ago, and to make it very short, we discovered that applying Sigh, we can have higher value of compliance compared to high PEEP level with a lower value of driving pressure. So going up with the lung volume once in a while do keep the recruitment without staying all the time to high PEEP value, and so trying to avoid the stretching of a high PEEP value. Sigh are normal. We do Sigh once in a while. This is a normal subject, as you can see. Once every 3 minutes, every 4 minutes, it takes a deep breath. We can apply Sigh also during pressure support. And we do it since many years. And I'm sure many of you believe that they can be dangerous. We just concluded an international multi-center study on feasibility of Sigh in patients with ARDS during partial ventilatory support, pressure support. The study ended up saying that patients with a Sigh, they have a survival similar and maybe better, but the point was not the survival. To see if it is safe, it is safe. It does not make any worse outcome. So we have to go ahead with this idea. How do we apply Sigh? We do use BiPAP on top of a pressure support level with the Pmax that is the same of the recruitment maneuver, with the inspiratory time is long enough to promote the recruitment, because the recruitment takes time, with the frequency, the lowest possible, never above 1 per minute. Better one every 2 minutes. And we demonstrated that they are effective in terms of oxygenation and expiratory lung volume and respiratory drive. And finally, I want to spend the last 5 minutes on something that I do understand is complicated, but I want to share with you. The risk of Sigh during pressure support in intubated patient. In other way, when we are in partial ventilatory support, assisted ventilation, we measure easily the pressure developed by the ventilator, this one. We do not know the pressure developed by the respiratory muscle of the patient. But I think you share with me the idea that the driving, even on pressure support, on every lung, in every condition, it does exist a driving pressure, that is the pressure applied to the alveoli during the tidal volume. And the pressure is the sum of this one plus this one. To know this pressure, you should use the esophageal pressure. I know it's not popular, so I have a solution for you. You can do it today on your patient. How? This is the pressure support. This is the effort done by the patient. You need to occlude the airway during pressure support at the end of inspiration using the old inspirator button. If you get a plateau pressure, following the occlusion, this is the plateau pressure that you would have get on controlled mechanical ventilation, and this one is therefore the driving pressure on pressure support of this patient. This is the case. Look at this patient. This is the patient on pressure support. This is the effort by the esophageal pressure. We occlude the airway. following the occlusion, the pressure, the plateau pressure, the pressure goes up. It reaches a plateau pressure, and this difference between plateau and PEEP is the driving pressure during pressure support. If this is one case, then if you increase the the pressure support, the effort decreases, the tidal volume stays the same, and the plateau pressure is still the same, and the driving pressure is this one. I know it's difficult. I know it's difficult. I hope you ask me something, therefore. But I wanted to, this is my last slide. It is important driving pressure during pressure support as it is important driving pressure during control mechanical ventilation. Just before pandemic, we published this paper in which we retrospectively, in approximately 150 patients, we looked at mortality related and driving pressure during pressure support. Higher the driving pressure, see 13, 14, higher the mortality. And also in a multivariate analysis is an independent factor of mortality, the driving pressure during pressure support. So my clinical practice, I do concentrate very much that my patient do not have a driving pressure exceeding 10, 12 centimeters of water. So my personal conclusion regarding lung protective ventilation is use NIV with caution and be aware of possible high tidal volume and Sigh, and prefer CPAP to pressure support in this patient. Tidal volume 6 ml per kilogram is a must, but driving pressure better. It is better tailored to the size of the lung of the patient. Avoid atelic trauma, applying a level of PEEP that is above the lower inflection point in order to reduce opening and closing. Adjust the PEEP according to recruitment maneuver, using SpO2, but maybe much better compliance, or even more electrical impedance tomography. Use the Sigh on volume control and pressure support to improve recruitment in a recruiter patient. It is safe, it is not dangerous, and we do apply. And finally, measure driving pressure on pressure support. And if it's higher than 12, consider to reduce it in any case. I'll thank you very much for your attention.
Giuseppe, many thanks for this very interesting presentation. We do have some questions, and I would like to read them through you. The first one are referring to APRV. Why 20 seconds? Isn't 8 or 10 seconds enough regarding the APRV intervention?
Yeah, this is an APRV modality used only on one breath, to have to do the recruitment. You still see my presentation, right?
Yes, we can.
Okay. The modality is APRV. Here it comes. Only in this phase is APRV. Only this phase. So volume control, one breath on APRV, 20 seconds long, and then go back to volume control. Why not 10? Well, maybe you're right. You can have recruitment also on 10 seconds, but sometimes 10 seconds are not enough to open up sticky atelectasis. That's my point. Anyway, we already decreased from 40. You remember 40 by 40? Now we move from 40 to by 20 because 40 is too much.
Okay, many thanks. The next question, do you assess who might be a recruiter, or do you perform recruitment maneuver regardless?
I do perform recruitment maneuver regardless, because I do not have a way to predict before the recruitment maneuver if the patient is a recruiter. But thank you very much for this question, because I skipped a slide, this one. But I am not capable to say before a recruitment, okay, this is a recruiter, this is not. But following one recruitment maneuver, I have three possibilities. Following a recruitment maneuver, SpO2 increases and stay up. So this is a recruiter, and maybe this patient does not have ARDS. It's just atelectatic. Okay, I did one recruitment, the lung open up, end of the story. Imagine following a lung surgery, in abdominal surgery in a septic patient, for example. Then I have another possibility. I do a recruitment maneuver and saturation goes up and then goes down. So this is a recruiter, but it needs PEEP adjustment in order to keep the recruitment. Finally, we have, and those are the patients that I show you during my presentation. Finally, there are patients in which I do perform a recruitment maneuver and they do not change SpO2 compliance EAT. Those are not recruiter. Usually those are old ARDS. In this case, I do not perform it anymore. I just keep calm and wait with a lung protective ventilatory strategy.
Okay, many thanks. Next question as well to APRV. What is the P low during APRV?
When I do a recruitment, I do repeat that my presentation was not on APRV, but I'm just using APRV to perform the recruitment maneuver. I do understand that I made the confusion. I do realize that. But please try to understand me. I'm not using APRV as my modality to treat those patients. I use APRV to perform a recruitment maneuver. Anyway, I do set P low at the same level of the PEEP from which I start my recruitment. So if my PEEP level was 5, and this is my volume control, I do set APRV with a P low of 5, PI of 40, inspiratory time of 20 seconds, expiratory time 3-4 seconds, but when it goes down, I switch immediately to volume control. I hope I was able to clarify my message.
I hope so too, Giuseppe. Many thanks.
Harry, do you understood?
Yes, for sure. Let's see how the attendee reacts. Next question. This is now on Sigh. How much should delta pressure be for Sigh?
Coming, yeah. Usually, we apply a delta pressure in order to achieve during inflation, the two inflation, a level of pressure that is the recruiting pressure that we want. Meaning, let's assume I have 15 of PEEP. My patient, I know, following a standard recruitment maneuver, that with 40 of pressure, I do open up the lung. So that I do apply 15 of PEEP as a conventional ventilation. Then I do apply a delta pressure of 20, and it goes from 15 to 35. Here is 35. And then starts the two ventilation. In order, be careful now, I know it's tricky, In order to avoid that the pressure of the two ventilatory cycle goes above 40, I set my P max level 5 centimeter over my limit, meaning P max at 45. I do repeat, PEEP of 15, the delta pressure of 20. The ventilator goes from 15 to 35. Then it starts the ventilation. If I don't do anything, the pressure maybe we will go to 60, 50, I don't know, it's dangerous. I don't want to reach this value. I want the ventilator to stop at 40. According to Dräger algorithm, then you have to set the Pmax at 45. So 5 centimeter above the level that you want the cutting level. Even this one is complicated. I don't know. Wait, you are the maker of the ventilator. Maybe think about it. Maybe make it slightly more easier. Okay.
We will discuss internally. Okay, we are already at the end of the presentation. Nevertheless, I think for one more question we have time, and the other questions, like said at the beginning, we will give to Giuseppe, and we will answer then later, and you can then later have the answers then. But this next question I just want to read. Can the PO1 measurement be useful in assessing the risk of Sigh in pressure support ventilation?
It can give you an idea that the patient is pulling a lot. Is an indirect evidence if the PO1 is well related to work of breathing. So you can think that if the P1 is 3, 4, 5, patient is pulling a lot, so is making a lot of transpulmonary pressure. Maybe so you apply 10 of pressure support, but maybe he's pulling some 7, 8, 10 centimeter more. But it's just a guess. Instead, I really do suggest you to go home and try to push the end inspiratory button. You will see that it is not so difficult. In more than 80% of the cases, you will find a plateau pressure coming. You will find this, see? The plateau pressure here. You don't need a long period of time, half a second, and you judge it by visual inspection. By visual inspection, I think we all agree that here we have a plateau and here we have a plateau. This is correct. I didn't show you all the study demonstrating that the plateau is a plateau. Trust me, plateau is a plateau, okay? But once you realize that this is a plateau pressure, then you have a really important number that help me to see if a patient should continue spontaneous breathing, or maybe I should go back to control mechanical ventilation. Many COVID patients, when I did switch them too early on spontaneous breathing, but they were still inflamed, they were start breathing stronger and stronger, and they were building up driving pressure, and the situation got worse. So in this case, if you cannot control driving pressure, I do suggest you to go back to control mechanical ventilation for some other days.
Okay. Many thanks. This was again a very interesting webinar. And like said, we will give you the questions which are now unanswered, and we will provide them later. To the audience, many thanks for joining in, and we will be happy to see you next time. And yeah, with that, Giuseppe, many thanks to you, and thumbs up and yeah, have all a nice day. Many thanks.
Okay.
Bye, Giuseppe.
Ciao.